speaking on complications of trabectectomy. Hope to finish within the 8-minute duration I've been given. No, yeah. So before I begin, I'd like to thank AIOC Chairman Scientific Committee 2023 for giving me this opportunity. So from managing complications, I would like to highlight this particular article by the Shankar Netralaya group, Dr. Ronnie George et al. And a very nice article came out in 2011, which still holds good water. I would suggest whoever is interested in the topic to go through this article. Most of the material in this presentation is from this, apart from my experience and our clinical work which we have done. So still a very nice article to speak to on complications of glaucoma surgery. Mainly I'll be touching on trabectectomy and pre-operative and post-operative also. So what we have shifted now is subtenance anesthesia, but previously if you were practicing surgery, you would really go in for periorbital anesthesia or retroorbital anesthesia, and you have a lot of these complications, acute retroorbital hemorrhage, perforation of the globe. So all that has almost reduced now since we have shifted to subtenance anesthesia. That is what we prefer now. You can have a lot of series of conjunctival related problems, mainly related to tears and holes in the conjunctiva, and the consequences also can be serious. Sometimes they can cause a failure. So why they occur is mainly because of poor visualization and poor exposure of the field and poor instrumentation, poor quality of the handling of the tissue, and their related surgeon factors, and poor quality of in situ mechanical errors. So management is important. You have to identify very quickly, and if it's a large area of tear, better to shift to a new site of surgery and direct repair that tear with a suture. All conjunctival leaks should be closed before the end of the surgery. Flap creation is again important. What we usually teach is that the bevel of the 15 number blade is about 1 millimeter. So if sclera is also 1 millimeter. So if your blade goes halfway through the sclera for creating a groove, whether it is for small incision or for glaucoma, for creating a flap, you are in the correct plane. So that's something you can think of. And if you have a flap tear, it's very difficult to repair. You have to take the tear into the bite of the suture. And if you have a flap amputation, you have to be ready with a donor scleral patch card for covering that area. Large scleral distance, again, you have to suture that area and then proceed to the surgery. And if you have large flaps, they usually produce a diffuse blips. Intraoperative bleeding, you can have conjunctival, scleral bleeding, or intraocular bleeding. And again, conjunctival bleedings are transient, mainly because the patient is hypertensive. That's the most common comorbid condition which we come across. And they will hamper, later on they'll hamper the suture lysis. Scleral bleeding, again, if you have it, you better keep a direct pressure with a cotton tip applicator, or you can even apply on table, you can apply brimonidine, which will constrict the vessels and reduce the bleeding. Intraocular bleeding can happen from the major arterial circle of the iris. So you have to increase the intraocular pressure to prevent it and then close the flap very quickly, and then thereby raising the stopping the bleeding. And if you have a large IPMA, then you naturally have to evacuate it using a paracentesis. Supraocular hemorrhage is a very important aspect. Risk factors include aphakia, vector-traumatized eyes, congenital glaucoma, pathological myopia, anticoagulant use, significant hypotony, prolonged hypotony during surgery, high baseline IOP, longer axial length, and prevention is by reducing the IOP before proceeding with the surgery by mannitol or gentle paracentesis, pre-placed sutures to prevent hypotony, and also you can use anterior sclerotomy as a preventive measure. So identification is very important, and shalling of the AC, loss of the red glow, onset of pain despite adequate anesthesia, appearance of a dark posterior segment mass, and management. Scleral flap should be closed immediately, intravenous mannitol should be administered immediately, and in select cases you can do an immediate sclerotomy, which are actually very beneficial. Per-operative surgical will consider topical, periorbital, or subtenance anesthesia. So avoid retroorbital anesthesia. Never use tooth forceps. Aim for watertight conjunctival closure. Lower pre-op high IOP, and never leave the operating room with an unclosed leak from the conjunctiva. Post-operative complications, we know traditionally they have been divided into high IOP with deep AC, high IOP with shallow AC, and low IOP with shallow AC and low bleb, low IOP, shallow AC, and diffuse bleb. So tight wound closure can be the cause of a high IOP with deep chamber. So you have to start losing suture lysis early. And if you do that, again, you have a paradoxical shallowing of the chamber because of overfiltering. And these blebs have a tendency to fail also, so you can plan bleb needling. Tenant cyst is nothing but the exteriorization of the anterior chamber, so it usually happens by 4th week. you have a tense, tight appearing bleb, and bleb is formed, no microcyst. And the permanent solution actually is to excise the cyst and revise the bleb. Shallow chamber with high IOP, you can have three complications, which are pupillary block, malignant glaucoma, supracorneal hemorrhage. Pupillary block is usually the first differential diagnosis with a central appearing deep chamber, central deep chamber, and posterior pigmental layer will be intact, supposing your iridotomy has not been complete. Avoid using the other problem is you may not have used sufficient steroid in the post-operative period. Because of inflammation, the PI would have got blocked, and it responds well to iridotomy. If you have the posterior pigment layer intact, you just do a small AIOC to it and it will open up. Malignant glaucoma is an important complication with a shallow chamber and raised IOP. The main predisposing factor is anterior chamber angle closure disease without a PI. So supposing you're operating in a patient with angle closure disease, don't have a PI, and sudden shalling of the chamber has a tendency to precipitate malignant glaucoma. So patient is usually asymptomatic, mild discomfort to severe pain. He may have the IOP may be normal or elevated, and the chamber can be anything from really flat to shallow and slightly deeper. And fundus examination, you can show aqueous pockets in high gain settings, and you will have to do a patent iridotomy to make sure that you are treating a malignant glaucoma. The important thing is that if you use atropine in these eyes, they respond to the condition. That means the condition responds to atropine. So the chamber will deepen, the refractive error will reduce, patient will be more comfortable, intraocular pressure will drop. So that shows you are actually treating a patient with malignant glaucoma. And the definitive treatment is to make the eye unicameral. So we had, I think, a talk yesterday or a free paper yesterday in which they did a iridotomy using laser, I suppose, but we prefer to do a full vitrectomy and make a communication between the posterior chamber and the anterior chamber and the posterior vitreous cavity. So that makes the eye very unicameral, and fellow eye may also develop the same thing, so you have to be very, very careful. Supracorneal hemorrhage has been, the incidence has been mentioned 2 to 7%. And risk factors I already mentioned. It's hemorrhage into the choroidal space. You have pain, congested eye, reduced vision. You have large choroidal detachments, and you have blood in the suprachoroidal space. Coming to congenital buttonholes, so risk factors, prior ocular surgery, poor tissue handling, the recognition is very, very important. And these are the main sites where you can have buttonholes in the, for example, limbus-based ribs. And the way to manage them is to apply a figure of 8 suture so that it's opposed very well. And if you have it at the limbus, you can just bring the congenital forward and suture it over the cornea. You can also use a purse string suture. Sorry. You can also use a purse string suture. Mitomycin C removal is very important. You should make sure that sponges, if you are using, they don't come out piecemeal. They should be removed in one go, and bits and pieces should not be left behind. If you happen to leave something like this behind, you may have a buttonhole like this. This is a mitomycin C sponge which was retained. Thankfully, it did not cause any complication except for a congenital defect. Scleral dehiscence, again, the risk of wound leak, shallow chamber is quite high. Risk factors include, like I mentioned, prior ocular surgery, thin sclera, and management is approximation using non-cutting needles. You can use a donor scleral autologous graft. So in initial, the management of suprachoroidal hemorrhage is initial conservative, but you will have to drain them. The indication of drainage is if you have 360 degrees CD with RD, kissing CD, vitreous incarceration, vitreoretinal adhesions. And then low IOP with flat blebs, these are the numerous causes. You always paint the bleb to see the defect. If you have overfiltering bleb, you can use torpedo bandage. You can also, if you find there's a suture leak line, for example, like this, then you have to bring the congenital forward and oppose it. So be careful with many of these complications. They have a tendency to occur in the other eye also. So if you have a complication in this eye, always anticipate the same complication in the other. This gentleman had the same complication in both the eyes, operated about 9 months apart. So I'll stop here since my time is over. Any questions, we'll be happy to take. Thank you.
Questions to Ganesh? I'm sorry I was late, but understanding that this was about related glaucoma also you mentioned. So I have a question. What are the signs that you know that you're facing an intraoperative malignant glaucoma? And is there something you can do on the table to prevent that and to make your case go?
Yeah, so for malignant glaucoma, usually we have have this problem when you're doing cataract surgery. That's one. If you're operating a glaucoma patient, in a combined procedure, you have a tendency to have that. In multiple glaucomas, you have a tendency to have that. So what happens is the improper pressure really becomes very high, and the chamber really collapses. You may not see the diffuse glow as in supraocular hemorrhage. You may not see a diffuse glow as in supraocular hemorrhage. That doesn't happen. So what you are actually happening is a transient raise in intraocular pressure. So three conditions we face that. If you are operating, for example, a pseudo-exfoliation glaucoma patient, and you are doing combined procedure by doing cataract surgery, you can face that. When you are suturing, you can face that. When you are made the ostium and everything hits the roof, then you can face that. So what we do is we suture very fast. And the best thing for malignant glaucoma is atropinization. The moment you put atropine, close the section, put atropine, everything reverses. Next day you will find that everything's normal. You never face this problem. It doesn't continue. So like I said, atropine helps you to not only treat it actually, it even the condition responds to atropine. So close very fast and give atropine. So that reverses. What I feel, I don't exactly know, but I've had this in cataract surgery, I have this in glaucoma surgery, had it in PRAB. So the moment I feel that in cataract, of course, I don't put atropine, but in all glaucoma procedures, if I'm doing implant surgery also, I face malignant glaucoma, I will give atropine as quickly as possible.
What are your thoughts about the panel's thoughts about intraoperative AIOC2023 to be able to disable the case? Because, so why I'm saying this, because I did it to one of the cases,
right.
and I just
All of
want
us.
validation that was that the right thing to do? Would I do the same thing when I...
So RK sir, if you see RK sir surgery, or if you have observed his surgery or been his OR, he'll put a needle through the iridotomy, through the zonules, and aspirate the vitreous. And that's okay, you could do that. If you have a good retina support, somebody can come and have a look and say that everything's okay, good. In a fake AKI, it's very, very difficult. In a pseudo fake AKI, it's possible. You could do that. I don't prefer to do that. That's really quite risky. We don't know how far the needle has gone in. But yes, it is an option for emergency purposes.
For me, what I do is like I put a stay switcher.
Yesterday there was a free paper on what you are saying.
Correct, yeah.
Dr. Siddharth Dixit had
He presented, yeah,
2007, and he said it worked beautifully, and he was vouching for it. He said if he could do it, it's not very difficult. We are taught that as soon as it happens, close the eye.
Close, yeah.
Close the eye, don't venture, give mannitol. But he said he used vitrectomy, he did it, and all 7 cases said.
Yeah.
So you could talk to him through the iridectomy.
Through the iridotomy, you could do that.
Iris,
But I've only encountered one case so far.
yeah, he's talked about 7. So you could talk to him.
Most of these eyes, if you see, most of these eyes will be angle closure, which has been missed, and PA may not have been done. So that's the whole gist of it. If you enter a chamber in an angle closure disease without a PA, very high chance of having this complication. If you do PA, let it settle, operate a few weeks or months later, then this doesn't happen.
I also want to add that we put stay switches while doing the surgery. So putting the stay switcher helps a lot. At the end, you just have to cut and place the IOL or whatever it is. Stay switcher supports you a lot, and mentally also will be much more in a good position to do the surgery, because all these angle closure disease would have had a IOP for a long time. So we don't know what will happen next. Some days we will have to extend it. So stay switcher helps a lot.
One more thing which has helped me is keep the AC formed no matter what.
Yeah.
So before making the ostium, put viscoelastic
Correct.
air, so that when you make ostium, there is no sudden decrease.
Sudden decrease.
So that's one thing which has helped.
And too much of viscoelastics also might sometimes push the iris out. So the mannitol, giving the intravenous mannitol 1 hour before the surgery, then we do that's a routine. That's 1 hour before the surgery, so that everything will be proper and well placed.
Should not also forget about post-op massage. That also plays very important. Using the pinky post-op.
Usually, if you don't cut the vitreous properly, it will reoccur. And how do you find that it is reoccurring? Is first of all, you would have stopped the atropine, number 1. Number 2, the refraction will start getting myope. So moment the patient who's left emetropic starts getting with minus 0.75, 0.5, and then comes to -1, that means the malignant glaucoma is slowly recurring. So what we do is we close the case and we do a full anterior vitrectomy posteriorly. We don't leave any vitreous, and then through that we do a complete. We have a separate package for this in our institute. Some places they don't have that. What they do is, because administrative reason, they charge the full vitrectomy package for this procedure. Because we face this common problem quite commonly. We allow the vitreous, and most malignant glaucoma patients, if you take the history, they would have gone in for many times. They would have gone in for corneal decompensation later. Because any anterior approach takes a lot of risk for malignant glaucoma. Turbulence is so high, you have very high risk of corneal decompensation.
And our VR surgeon group, they say that less manipulation will be better for them. So
Yeah.
they tell us place IOL in the surface close.
Close, we'll take care of it. So they have a separate package for the moment you label it as malignant glaucoma and anterior vitrectomy, it goes into a 13,000 rupees package rather than a 38,000 rupees package.
Thank you, sir, for
Thank you.